Hello, everyone. Welcome. I'm just going to present Dr. Amy Hanson. She was the infectious disease pharmacist at Rush University Medical Center for 7 years post PGY and PGY2 ID residency training. Currently, she's the project administrator and antimicrobial stewardship at Chicago Department of Public Health since 2018. So thank you all for coming, and here's Dr. Hanson.
All right. Thank you for the introduction. Good afternoon. Amy Hanson, and the content of today's presentation will focus on the experiences I had as an infectious disease pharmacist at Chicago Department of Public Health. I'll be discussing the principles and practices of antimicrobial stewardship in the outpatient arena. And actually today is my second day at a new job. I'm currently a medical science liaison at a microbiology laboratory diagnostic company, IDbyDNA, which uses metagenomic next generation sequencing technology that can identify thousands of pathogens. So the objectives of today's presentation are to review fundamental principles of outpatient antimicrobial stewardship programs, including the 4 CDC core elements: accreditation standards, tracking and reporting of quality metrics, and key interventions to advance the stewardship agenda. Next, we'll describe an urban educational public health antimicrobial stewardship campaign with a focus on urgent care, primary care, and dentists. We'll illustrate lessons learned and future opportunities for antimicrobial stewardship collaboratives in the ambulatory care setting. And lastly, we'll explain the PACCARB's, or the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria, recent recommendations for outpatient antimicrobial stewardship and telemedicine services. I have no conflicts of interest to disclose. So we'll first broadly introduce some principles applying to outpatient antimicrobial stewardship. The CDC estimates that at least 30% of antibiotics prescribed in the outpatient setting are unnecessary, and that total inappropriate antibiotic use may approach 50%. Unnecessary antibiotic prescribing can vary depending on outpatient settings, but tends to be the highest in urgent care clinics. Fluoroquinolones have really fell out of favor over the past years and are no longer recommended for simple infections. There is also concern for increased resistance rates, particularly to avoid use for urinary tract infections, and an increased emphasis to clarify penicillin-based allergies before prescribing fluoroquinolones, such as levofloxacin or ciprofloxacin. The more time went on with fluoroquinolones on the market, the more we learned about their toxicities, including increased risk of Clostridioides difficile or C. diff infections compared to other antibiotic classes. Additionally, a CDC publication in Antimicrobial Agents and Chemotherapy from 2019 demonstrated compliance with first-line antibiotic selections such as pharyngitis, sinusitis, and pediatric acute otitis media, according to age and across settings in 2014. Only 50% of visits for these conditions received recommended first-line antibiotics, and macrolides were the most common non-first-line therapy. And as you can see, office visits, urgent care visits, and adult emergency department visits had the lowest compliance. 10 days is a common duration prescribers like to use. When the more we learn when comparing shorter and longer durations for various infections, the saying is shorter is better often applies. Antibiotic prescribing nationally has improved with a 5% decrease from 2011 to 2016, according to a 2018 CDC report. But more progress is needed to be made. In 2016, 270 million antibiotic prescriptions were written in the United States. That's enough antibiotic courses for 5 out of every 6 Americans on average to receive an antibiotic prescription. Prescribing rates vary by state, with a 2.5-fold difference between the lowest and highest prescribing states, suggesting there are opportunities for improvement. Illinois is right in the middle, not the highest, but also not the lowest in prescribing not the lowest in prescribing antibiotic rates per 1,000 people compared to other states. For outpatient, CDC has 4 main core elements for an antimicrobial stewardship program, or ASP. These are similar to the 7 CDC core elements of ASPs for hospitals that many of you may be more familiar with, but condensed down into these 4 elements of 1, commitment, 2, action for policy and practice, number 3, tracking and reporting, and number 4, education and expertise. The CDC's website for core elements of outpatient antimicrobial stewardship also has a helpful, both for clinicians and facilities, checklist that can serve as a valuable tool when establishing and/or enhancing an outpatient ASP. The Joint Commission also has standards for outpatient antibiotic stewardship programs, or ASPs. And I won't read through all of these, but they are similar in recommendations to the CDC core elements for outpatient ASPs. One component that is specifically recommended is number 5, counseling patients on rationale for or against antibiotic prescribing. So there's a whole separate alphabet soup of acronyms used to describe quality metrics and measurements in antibiotic prescribing in the outpatient arena. And antibiotic appropriateness compliance metrics are tracked by the HEDIS measures, or healthcare effectiveness data and information set that outpatient clinics are required to report to. So I've defined measures for Medicare and Medicaid reimbursement mechanisms on this slide as well, with MACRA, MIPS, and CHIP. The HEDIS measures don't cover all indications for appropriate antibiotic prescribing by indication, but do address some of the lowest hanging fruit, such as avoiding antibiotic treatment in adults with acute bronchitis, appropriate treatment for children with upper respiratory infections, and appropriate testing for children with pharyngitis. Clinics are required to report these HEDIS measures about their performance on various services and types of care to NCQA, or the National Committee for Quality Assurance, which then rates health plans based on performance. This is an example of how outpatient facilities can track and report their compliance with HEDIS measures over time. And before I describe the outpatient antibiotic stewardship educational campaign, supported by CDC and developed by Chicago Department of Public Health, or CDPH, I wanted to start things off by defining what my former position at CDPH looks like. What would an infectious disease trained pharmacist do at a health department? The position in the CDC grant is referred to as the ARAS expert, or antimicrobial resistance antimicrobial stewardship expert. CDC funds state, county, and local health departments, and the CDC grant is called ELC, or Epidemiology and Laboratory Capacity. Our HAIAR, Hospital Acquired Infection / Antimicrobial Resistance Program, has funded activities for the City of Chicago and includes salary support for the ARAS expert, an infectious disease trained pharmacist. The ARAS expert develops and sustains antimicrobial stewardship programs in a variety of high-risk healthcare settings, with a focus on settings with patients at highest risk for multi-drug resistant organisms, emerging pathogens such as Candida auris, and patients at high risk for adverse consequences of antimicrobial use and overuse, such as patients at risk for Clostridioides difficile, or C. diff infections. It was an awesome, absolute dream job. My family moved to Naperville recently, and you need to live in Chicago to work for the city. So plug, I'd be happy to talk about it more if any of you infectious disease pharmacists in the audience or our other colleagues are interested in the position when it becomes back open again. I couldn't help myself. I had to get a plug in there for my former team. So I'll now describe how outpatient antimicrobial stewardship collaboratives start with that first, which was an educational campaign with a focus on urgent care, primary care, and dental providers. This is a CDC chart of high volume prescribers by outpatient specialty that helped us target our intervention. Note, we used this to target provider types highlighted in red, number 1 and number 5, family or primary practice providers, and dentists. So let's start with the dentists. Dentists prescribe almost 3 million antibiotic courses annually, and they're not all single dose pre-procedural. Actually, the most common durations are 7 to 10 days, and reports suggest that 30 to up to 85% of dental antibiotic prescriptions are suboptimal or not indicated. And the ADA, or the American Dental Association, had recently published treatment guidelines on antibiotic use for the management of dental pain and intraoral swelling, sort of first of their kind. So the CDC funded CDPH to develop and distribute outpatient antimicrobial stewardship binders, posters and brochures in almost 500 Chicago immediate/urgent care and primary care and dental clinics. And the binder toolkit contents are available on our Chicago HAN, or Health Alert Network, website subpages, and the links are at the bottom of the slide. So I have pictured the cover of I'll refer to it as urgent/primary care binder, and the opening letter in the binders. And then the dental binders mirrored this format, and additional materials for dentists were distributed on a second round of refresh materials. I hand laminated about 200 pocket cards that were CDPH developed treatment and prophylaxis guidelines mirroring the new ADA stewardship guidelines for Chicago dentists. And pre and post paper surveys were administered during and after educational campaign content delivery, September to November 2019. And the second round of dental educational trifold folders with the laminated pocket guides went out January and February 2020. Directly prior to many dental clinics shutting down from COVID. Pre-survey response rate was about 10% for immediate and primary care clinic locations and about 20% for dental clinics. The majority of survey respondents were clinic administrators and the rest were clinical staff. There was various compliance with the 4 CDC core elements of antibiotic stewardship programs with the 2 main provider types. And lowest compliance was seen for education and expertise. Other areas of low compliance for all clinic types included designation of ASP leads, so kind of plug for FT salary support for an infectious disease pharmacist or provider in these settings, and then use of evidence-based antimicrobial treatment guidelines. Prioritizing tracking and reporting of compliance with antimicrobial guidelines, and providing annual antimicrobial stewardship education and feedback on prescribing patterns to clinical staff. This table shows the survey results that we just covered in a little more detail. For core element 1, leadership commitment, 26% of immediate and primary care clinics indicated they have individuals designated to lead their ASP, compared to 66% of dental clinics. For core element 2, action, I'd like to highlight how evidence-based antimicrobial treatment guidelines are used in 42% of immediate and primary care Chicago clinics, compared to 60% of dental clinics in Chicago. For core element 3, tracking and reporting, both immediate and primary care clinics and dental clinics self-assessed that, on the last point, quality measures and performance goals are prioritized, but only 10% for immediate primary care clinics and 36% for dental clinics. And lastly, for core element 4, education and expertise, 35% of immediate and primary care clinics reported that they provide annual in-person antimicrobial stewardship training for clinical staff, compared to 55% of Chicago dental clinics. And we based much of the content off the previous Illinois Department of Public Health, or IDPH, campaign for primary care and dentists, the Precious Drugs and Scary Bugs campaign. And on the right, that toolkit contained some sample ASP commitment posters. And these next 2 slides I'll go through kind of quickly, but just to provide an overview of some of the main toolkit contents. These are various toolkits and a field guide that has been developed to help facilitate implementing an ASP in the outpatient setting referred to in the binders. The binders also came with brochures and posters. Here are a few examples of the printed posters, and the antibiotics are not right for a virus was also available in Spanish. Here's an example of one of the recipients of the dental binder and opening letter to the dentist. And this is another example of dentist education specific to facilitating penicillin allergies discussed between providers and patients. I developed the CDPH dental guidelines with two dentists, so shout out to Susan Rowan at UIC and Aaron Kennedy is primary author on the new dental stewardship guidelines. And thanks also to two UIC PharmD colleagues that helped me along the way, Alan Gross and Katie Suda, when I started off on my dental stewardship adventure. I also adopted the figure from a recent Deb Goff awesome publication that's a doctor-patient shared decision-making tool for deciding on prophylaxis prescribing of antibiotics to prevent development of a prosthetic joint infection. There was also a beta-lactam counseling component of the Dental Stewardship Pocket Guide that gives the stats on how rare true penicillin allergies are, less than 1%. And information specific to dental prescribing on the low cross-reactivity between penicillin or amoxicillin and cephalexin, less than 5%. And also how clindamycin, even after a single dose, comes with an odds ratio of 17 to 20 increased risk of C. diff infections. And so for the patient to walk out with of a dental appointment feeling like they really have a prescription in hand, in the refresh material folder, I included pain management handouts for rotating ibuprofen and acetaminophen that said antibiotics won't cure a toothache for adults and pediatrics. Here's the CDC-developed dental trifold brochure for patients. And then post-survey feedback on the CDPH educational campaign is available for immediate and primary care clinics. And pending for dental. Response rates post-survey were about 20% for immediate and primary care locations. Respondents were most commonly a clinic administrator, 45%, and the rest were clinical staff, providers, pharmacists, and nurses. 93% of respondents reported that CDPH antimicrobial stewardship materials prompted patient-provider conversation at some point. And 63% experienced growth to either partial or full compliance of the CDC core elements since receiving the educational materials. Another recent initiative is a CDC-directed antimicrobial stewardship intervention for any participating state health departments. So I helped Illinois Department of Public Health validate the Chicago IQVIA data. So IQVIA is an IT company with a data warehouse of 92% of all outpatient antibiotic prescriptions. They supplied IDPH with a list of top 10% of antibiotic prescribers in an outpatient setting in Illinois. Letters to these prescribers and a survey capturing antibiotic prescribing patterns will be distributed in the near future. These letters have been shown in the literature previously to improve antibiotic prescribing practices for these providers moving forward. The specific provider types targeted were based on previous literature of higher prescribing rates, including internists, family practitioners, nurse practitioners, physician assistants, pediatricians, dentists, and urgent care providers. So here's a look at the new Chicago Department of Public Health HAN, or Health Alert Network, page dedicated to antibiotic stewardship. And then one subpage for outpatients has the Outpatient Antimicrobial Stewardship Toolkit binder contents and other resources posted. And the dental subpage also has campaign content, including the original binder, brochures and posters, and the refresh of materials that included guidelines and the laminated pocket card. The CDC also offers free continuing education credits for many different types of healthcare professionals to train them on core antimicrobial stewardship principles for the outpatient setting, and also particularly dentistry. Some next steps for this collaborative would be to retrieve feedback from the 200 dental clinics that received the antimicrobial stewardship refresh materials January and February of 2020. As mentioned, I'm no longer a CDPH, so this is more of my sort of wish list and brainstorming of potential next steps in the dental clinic in our jurisdiction, Chicago. I'd love to collect more prospective data on appropriateness of antibiotic prescribing for dental indications in the future, as retrospectively that would be difficult given limited shard documentation of signs and symptoms and indications, and provide some feedback to individual dentists compared to peers. Additionally, I had created a survey of prescribing patterns for dentists, but it had not been deployed, as again, that was around March of 2020 when we shifted gears to all hands on deck for the COVID response. And I on the job trained actually as an infection preventionist on the COVID nursing home response team. And speaking of skilled nursing facilities or SNFs, outside of the scope of this talk, but I'd also envision extending the Antimicrobial Stewardship Collaborative I piloted in 4 Chicago SNFs pre-COVID that would be able to demonstrate an aggregate, I was able to demonstrate an aggregate improvement in antibiotic prescribing at each facility. Overall, inappropriate prescribing was reduced from 71% to 44% pre versus post point prevalence survey assessing appropriateness of antibiotic prescribing. And then the long-term acute care hospitals, or LTACs, are another high risk for multi-drug resistant organism setting to future tackle enhancements in their antibiotic stewardship programs. All right, so back to the dentist. This is the survey I mentioned. It starts with demographic and contact information. And I asked for feedback on the educational content of the campaign. I also asked for selection of infective endocarditis prophylaxis indications for antibiotics. And then I got a little tricky on them and scrambled the correct guideline recommended indications with common inappropriate reasons for antibiotic prescribing. And then the dental endocarditis prophylaxis guidelines have been revised to encourage more judicious use of antibiotics in the past, but some dental training in the classroom and in clinical practice is not accurately reflected with the updated changes. So some dentists continue to prescribe antibiotics prophylactically out of fear for being sued for an exceedingly rare chance of endocarditis. And more education focused on explaining how you could similarly become transiently bacteremic every day just by brushing our teeth, I think is warranted. So same here for when dentists prescribe antibiotics to prevent prosthetic joint infections. This is also a common practice, but an example of inappropriate prescribing. So it ends with treatment indications for antibiotics and dental prescribing. All right, switching gears again to address our last learning objective, let's talk about how the PACCARB, or the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria, this year created 2 work groups, and each was tasked with producing a report with recommendations. A summary of each report was presented recently at the last PACCARB public meeting on June 29th and 30th, 2021. So one work group was on advancing interprofessional education and practice to combat antibiotic resistance. The other work group was assigned to bridging the gap in improving antimicrobial access and use across the One Health spectrum, which refers to thinking about antimicrobial stewardship not only for humans, but also companion and farm animals, plants, particularly crop, and environmental health, since they are linked to how the health of one sector can affect the health of another sector. So my former boss, Dr. Stephanie Black, who's the medical director of the Communicable Disease Program at CDPH, is a voting member of PACCARB, and I co-led this work group with Dr. Locke Carricker, a veterinarian, and I was lucky enough to be part of the process on the monthly meetings and providing recommendations for edits to the report. So the two workgroup reports are available for public viewing now on the HHS website, filed under the June 2021 meeting. This workgroup's recommendations were divided into two aims. One was the persistent gaps in antimicrobial use research, such as recommendation 1, increase funding of research investigating the impact of virtual healthcare delivery on existing and new health disparities related to antimicrobial use. Recommendation 2 and 3 focused on antimicrobial stewardship efforts in several agricultural crop domains. And then recommendation 4 discusses the need for antimicrobial use and resistance tracking and reporting systems for food and companion animals. So what I'll focus on is the second set of recommendations, since it pertains to outpatient antimicrobial stewardship and particularly focuses on the virtual care setting. This infographic summarizes the first aim in closing persistent gaps in antimicrobial use research across the One Health spectrum. And like I said, does focus on health inequity and disparities. And this infographic focuses on what we'll be discussing, the 3 recommendations 5 through 7 that address advancing the antimicrobial stewardship agenda in the virtual care outpatient setting. The recommendations have both a human and animal component to them. So for the focus of today's presentation, I'll just discuss the human side, as I'm not quite sure we have that many veterinarian colleagues in the audience today. And then each recommendation ends with suggested mostly national organizations to tackle, sustain, and create incentives for each of these issues discussed. So first, let's start with some key definitions. Virtual care is defined by any interaction between patients and/or members of their circle of care occurring remotely using any form of communication or information technologies with the aim of facilitating or maximizing the quality and effectiveness of patient care. Telehealth is a two-way, real-time, interactive communication between the patient and the physician or practitioner at a distant site, such as a patient's established medical home. And that includes audio and/or video equipment. And direct-to-consumer, or DTC, telemedicine is a subset of virtual care where the visit is initiated by the client patient with no intermediary clinician, with the visit taking place completely online. So first, I'll provide a little bit of background on antimicrobial stewardship in the virtual care setting described in the PACCARB report. Virtual care includes both telehealth services connected to established outpatient practices and direct-to-consumer DTC telemedicine. A 2020 study found that 86% of telephone prescriptions from a DTC care provider were for broad spectrum agents, compared to 56% of prescriptions made during in-person physician visits. DTC practices are particularly concerning that a patient could go online to visit a website and enter symptoms and essentially self-diagnose, for example, something like sinusitis, and obtain an antibiotic without a provider review. Recommendation 5 says to collate, review, and evaluate current federal policies, regulations, and requirements for antimicrobial stewardship and develop new incentives to better standardize stewardship practices across different modalities of care delivery, with a focus on telehealth. To summarize recommendation 5.1, additional funding should be allocated to the CDC to expand support for state and local health departments to implement programs to hire trained staff to track and provide feedback on antimicrobial use data to outpatient prescribers. So, woo, I like that one. To summarize recommendation 5.2, CMS should develop a task force to review the effectiveness of current incentives and develop a recommended list of new ones to encourage additional data reporting for all outpatient settings, including telehealth. We need regulations, standards, and guidelines adapted to address concerns regarding the standard of care given through telehealth platforms. We also need to develop regulations and billing incentives to encourage the tracking and sharing of prescription data, such as use, location, and demographics. And there is a call for expansion of antimicrobial use quality measures into the Medicare Merit-Based Incentive Payment System, or MIPS, program, and requiring the mandatory reporting of current and new antimicrobial use measures. Recommendation 6 focused on the need for increased access to data about individual prescribers and create actionable feedback to improve antimicrobial stewardship. For a summary of recommendation 6.1, payers, large health systems, state and local health departments, and other stakeholders that have infrastructure and data to improve prescriber-level data should provide consistent and ongoing feedback of physician performance for antimicrobial prescribing in the virtual care setting, with a focus on non-antimicrobial treatment that can be offered to patients and clients, training on how to communicate with patients, family members, and clients about antimicrobials and their potential health risks. And last but not least, something I highly recommended to include, clinical decision support software with electronic health records to support point-of-care decision-making. To summarize recommendation 6.2, it focuses on veterinary practices and implementation of a feedback system. Recommendation 6.3 discusses the need to allocate grants and other resources to support research validating the proposed feedback process and to assess its effects on adherence of antimicrobial stewardship practices among both human and animal prescribers. Recommendation 7 discusses the need to adapt and apply existing antimicrobial stewardship resources and tools to virtual care settings, specifically direct-to-consumer telemedicine. For a summary of recommendation 7.1, it discusses the need to characterize antimicrobial use in DTC telemedicine, including by gathering appropriate and actionable data on the type of prescribers and their prescribing practices with DTC telemedicine delivery to provide more meaningful information for these practitioners. Recommendation 7.2 discusses to adapt and tailor existing educational and communication tools to better support antimicrobial stewardship and appropriate prescribing behaviors among the wide variety of prescribers within the DTC telemedicine landscape. Recommendation 7.3, which I promise it's the last one, calls for funding the creation of tools that help streamline the development of protocols and antimicrobial use decision-making processes for veterinary practitioners that could be used in various care settings, including virtual care. So that's all I had, and I thank you for your attention during today's presentation. And thank you so much to my hardworking teammates for all that you've done to advance the antibiotic stewardship agenda in Chicago. And I can take any questions. So I don't see any direct questions in the chat yet. I did also put a new email address on the second to last slide. Let's go back. If you have any. So, well, I think I forgot to switch it out. So that's my old email. My new email is A, like an Amy, Hanson, Hanson, at IDbyDNA.com. Oh, that Amanda Kaplan asked, that's the golden question. That's such a good question, which I don't have an answer to, but it was discussed in the PACCARB work group meetings and made it into the recommendations, but I do not have an idea of how soon we may see antibiotics in the MIPS measures. Sorry, I don't have a better answer for that. I can try to find out and let you know if I hear anything moving forward for sure. Yeah, I totally agree. So Mark Gregg says, as you can tell by this presentation and the previous presentation, pharmacists are uniquely qualified to improve ambulatory antibiotic use as well as to assist with managing other commonly encountered medical conditions such as diabetes and ambulatory care. I certainly agree. If I had it my way, I could open up a spot for an infectious disease trained, I'm biased pharmacist, but like provider, as somebody specifically trained in antibiotic stewardship at any outpatient setting, because the hospitals don't always have enough ID pharmacist FTE for the inpatient team, but are certainly much more well-funded on that side than being able to have time to adventure out and tackle some of the ambulatory antibiotic stewardship initiatives. I know that was definitely my experience when I was practicing at Rush. We were able to do a study in the outpatient ambulatory care clinics where really all we did was come up with treatment algorithms and put the antibiogram on a pocket card, same as we do with inpatient, and distribute it outpatient. I introduced it at a clinical meeting where like all the project manager for the department of all the ambulatory care clinics was there, and we just sort of mass distributed it. And it was able to, and with some education as well, but not an extensive amount, it was able to show a decrease in fluoroquinolone prescribing because we put an emphasis of beta-lactam allergies by about 10% kind of pre and post intervention. So I definitely agree that there needs to be more support for being able to do these initiatives in ambulatory care. Rachel, do you see anything that I might be missing?
No, I'm just seeing the last, Mark did a last comment.
Mouse is just being wonky with scrolling. Okay. Gotcha. All right.
So if anybody has any questions, please put it in the chat box for Amy.
Yeah, there we go. Now it's working. If not, we can wrap up. I don't know if you wanted to wait a couple minutes or.
Yeah, we can wait, or if anybody thinks of anything in the next couple of minutes to put in the box, that's totally fine. We do still have the time.
Yes, hi, this is Shannon. I was able to hop in. I agree with you both. Maybe just wait a few minutes, see if anyone's currently typing anything or if they think of anything. Otherwise, everyone else is free to join one of the ongoing sessions, or we have a 10-minute break coming up. Maybe you want to take advantage of the extra time and have a longer break, stretch your legs, just whichever works for you. But I definitely recommend for Amy and Rachel to hang out here for at least a few more minutes, just in case.
Sounds good.
And Amy, can you mention your email again? I'm just going to type in the chat box for people just in case anybody didn't.
Yeah, I forgot I was going to flip that on for the Q&A. Yes, it's A Hanson, so AHANSON at IDbyDNA, IDbyDNA.com.
Amy Hanson at IDbyDNA.com. Okay.
Yep.
Oh, there was like a hyperlink to your name with your email from when you signed up. Perfect. I'll post that.
Oh. Awesome.
Hi, everyone. It's Shannon again. I just wanted to share that if you guys are all done and don't have any questions, there's a really good presentation going on right now in the dental session about penicillin allergies that may be of some interest. Of course, all the sessions right now are great, but I was just in that one and I was very interested. So I thought if you guys are all done, you might want to head over there.
Sounds good.
I know you're a big proponent of penicillin allergy work,
Yes.
Amy.
Yeah, for sure. Children are screaming outside. It's like I worried that was going to happen during the presentation. My husband's mowing, children are screaming. All good.
Yeah, it looks like the viewers are going down, so I guess we can give someone a minute, and then if you're ready, we can end this session. And Amy's contact information is in the chat box if you all need her email. And thank you so much, Amy, for presenting.
Oh, it was my pleasure.
I'm glad there were no problems and you're able to put on your camera and everything was working well.
Me too. Yeah. Yes. Yes. I was happy to the little last minute. I was like happy to hop on it. I'm like, yes, I'll do it.
Okay, thank you to everybody who came. And like Shannon said, if you wanted to join another presentation, or you could just use this to take a longer time, stretch your legs, get something if you need. Thank you so much.
Thank you, everyone.